The status of health care insurance in Louisiana is that it's improved greatly since the Affordable Care Act was introduced, allowing availability and access to health care insurance to many more people. And of course, with the expansion of Medicaid, that put another couple of 100,000 people on the insurance rolls. And with Medicaid having a private component in that there are, managed care organizations that now contract with the state to provide that service, we have been able to really increase access in the state. However, all of those programs are now challenged, and they're under challenge in the United States Supreme Court as we see some of those legal challenges with respect to the Affordable Care Act and the mandate and how that could impact Louisiana. And that could have serious repercussions to our budget as well, and how we're able to afford health care on a statewide basis going forward.
It is still quite a challenge, has been for many years, including the last 10 since the passage of the Affordable Care Act. And now that is being challenged at the Supreme Court, who just this week scheduled or announced that they will schedule oral argument on the case that emanated out of Texas to have the Affordable Care Act ruled unconstitutional. We were tasked by the legislature at the Department of Insurance to create a replacement for Louisiana policyholders in that event. We are prepared to do that. We have provided for most of the popular parts of the Affordable Care Act, age 26, staying on their parents' policies, no lifetime or annual limits on health insurance. The one that remains that's popular also is guarantee issue, no pre-existing conditions. And we are working as we speak to design a state system of a limited enrollment period similar to the federal law if the federal law goes away. We're also working to lower the cost of individual health insurance policies by doing a state-based reinsurance program that would attract $100 million from the federal government in the savings that they would realize by lowering the cost of those policies they subsidize under the Affordable Care Act. And surprise billing. That's been around for a decade and now has resonated all the way up to the Congress. I am working closely with Senator Cassidy on legislation he's proposing to fix that problem, all the way to the White House. The President has spoken out on the need to fix surprise billing that has been a really bad part of our health insurance system throughout the United States, and about half of the states, like Louisiana, still have not been able to effectively address it. The battle of balance billing, now known more appropriately as surprise billing. We evolve with these terms that as we go along and learn more useful words to describe what we're doing politically all across the land and beyond, it works out that way. I particularly have been involved with this issue for over a decade and was initially thinking that, oh, well, this is so obvious, it'll be easy to fix. Not. And so here we are with a truly august panel to talk about it for the next hour.
Thank you all for having me. I know y'all are very busy, and I appreciate y'all taking out your time of your busy schedules to be here. I guess I'll just kick this off. I'm not in healthcare. I'm in hot dogs, so don't know any. Never was in the healthcare business, but I'm a consumer. I have health insurance, and I never had heard the term balance billing or surprise billing until 2008, which was my first year in the legislature. And I believe some people had filed some balance billing legislation. We had some people come and testify, and when that happened, I kind of realized that I had been balance billed on a couple of things, not big monetary issues, but enough to be aware of it. And the more we started diving into it, talking to different legislators and different constituents, realized, how big of a problem it is. And, I'm regretful to say that we really haven't done a whole lot since then. I did pass a bill a few years ago that gives you a notification on, what balance billing is, like when you go in for a scheduled procedure, It's an extra thing to read, like we all really want that, but something that you sign saying that, this is what balance billing is. Please talk to your provider. Please talk to your doctor and whatever to make sure that this won't happen. Well, I don't know how good that is doing. It's something that I think we need to really take the consumer out of it. And that's really what my goal of my legislation this year is. And ironically, I'm not exactly sure what that legislation will look like. I filed one kind of a placeholder bill, probably going to file another one this week, but have an idea of where we want to go. But the basic crux of the matter is I want to take the consumer out of this. The consumer did nothing wrong. The consumer should not have any fault in this. Funny thing, I had shoulder surgery about 2 years ago. And I thought to myself, well, this is going to be fun. This is going to be a little interesting thing. I'm going to try to find out, use myself as a guinea pig. So I called my insurance company. I said, well, is everybody involved in my scheduled surgery in network? Well, we don't know. You need to talk to your doctor. So I talked to the doctor. He said, well, no, you really need to talk to the hospital. And the hospital said, well, we're not really sure. I'm not the one that does that. You probably need to talk to your doctor. So I just went round and round and round. And, I found it shocking that all the people with the master's degrees and the PhDs and the college degrees that are involved in this process cannot tell me whether my anesthesiologist or whoever is going to be on network that day, yet be in my network. So it's very frustrating from a legislative point of view. We get, especially being chairman of insurance committee, I'm the one who gets all the emails. If a state rep who's not on insurance committee in Alexandria has a problem with a constituent being balance billed, they push them on to me, and that's fair. But it's just frustrating that we haven't really done anything yet. I know on the federal level, one of our senators, Bill Cassidy, Dr. Cassidy is kind of taking this by the horns and trying to get something done. I guess if I can put on my state rights hat, I don't really think the federal government should come in here and do this. We can fix this on our own. And I would encourage everybody in this room who has a stakeholder in this to let us fix it on the state level, because if we do something that may have an unintended consequence on the federal level, you got a lot easier time sitting down with me or sitting down with the commissioner or sitting down with my House counterpart and fixing this problem, coming to session. Maybe we'll do an amendment to fix it or tweak it. But on the federal level, that's a very, very difficult thing to do. And it's not a one-size-fits-all solution, although we all seem to be suffering from the same thing. So with that being said, I really want to solve this problem this year. Something that really is meaningful and something that, we don't have to rely on the federal government to do it for us. So with that being said, I'll let some of the other gentlemen on the panel speak, and we'll go from there.
So my name is Joe Tushner with NAIC. Wanted to provide a perspective from the federal level and picking up on a couple of things that Senator Talbot said. First, I just want to say I appreciate the chance to participate in this panel. I may have to cut my participation a little bit short so that I have time to stop at Lucky Dogs on my way out at the airport. But looking at the activity in Congress, in a divided Congress where not a lot of legislation is moving, and legislation that does pass one house tends to die in the other house, surprise billing is really someplace where we've seen a different story. We've seen legislation move on a bipartisan basis in both the House and the Senate to address surprise billing for the reasons that we've heard, that it's clearly unfair to consumers, that it impacts them through no fault of their own, and that there ought to be a way to address this and come to a reasonable payment amount in these situations. We've seen activity by 3 different committees on the House side, by 1 committee in the Senate. There was, in fact, an agreement between the House and Senate on a surprise bill solution at the end of 2019. that was stalled by activity in another House committee. So there's a number of committees that have jurisdiction that want to get their priorities addressed in this legislation, and that's been holding things up. So we're not at the finish line yet, but there continues to be progress. As we've worked on that legislation, from the NAIC perspective, I think we've really pushed 3 priorities, that you've heard mentioned already. One is just getting consumers out of the middle. Maybe 2 of these priorities you've heard before. One I'll add. Getting consumers out of the middle because it's unfair to them. 2, protecting state laws in this area. I think even if there is a federal solution, we're working to make sure that it leaves room for, still going? We want to make sure that it leaves room for state solutions that exist. Not just state solutions that exist today, but as Senator Talbot was saying, if there is an issue with the federal solution in a particular state, there needs to be room for a state to change its laws in response, for a state to provide its own adjustment or own payment amount if state legislators decide that that's most appropriate for their state. The 3rd priority for NAIC is to include air ambulances in surprise bill legislation. It's a service that is thankfully rare. Not in the scheme of things, not many people need air ambulance transport, but when they do, it can generate an enormous surprise bill in the tens of thousands of dollars, and that's something that we feel like only Congress. Well, we're certain that only Congress can address it because of the federal law, the Airline Deregulation Act, that prevents states from regulating air ambulances. That law and the way that federal courts have interpreted it have really left states, even if Louisiana passes a surprise bill, it will be unable to regulate the prices and the balanced billing practices of air ambulances because of the federal law. So that's been a point that we've been stressing. You'll notice in my 3 priorities, keeping consumers out of the middle, protecting state laws, and including air ambulances, I did not mention a payment strategy. I think that's, the setting the amount is certainly one of the key things at issue in surprise bill legislation at the federal level and at the state level. At least insurance commissioners have not weighed in on that. I think that's something that we don't want to see, premiums rise because of this type of legislation. But the appropriate amount is something that, the processes that are in the eventual legislation can get to, and we haven't weighed in on that yet. I think I'll let the folks from the health plans and representing providers, talk about those issues a little bit more, but just wanted to give an overview of how we've been approaching it at the federal level at NAIC.
Sure. Jeff? Doc?
Hello. I'm an emergency room physician. I want to give you just a little bit of a perspective as a provider who's worked in Louisiana for 20-something years, and sort of give you my story on how my business...
Pull that closer. There you go.
Better?
Yeah.
Got it. To begin with, I'll say that the number of people that have come to me when I told them I was going to be here on this panel and said either, "Oh, you poor darling," or "Who talked you into that?" Senator, I refer to that as a clue to me. So again, it's a challenging problem that we deal with. So there isn't, and my perspective is going to come from emergency medicine, from a hospital base, a community hospital, St. Elizabeth Hospital in Gonzales. We're a bedroom community to Baton Rouge and to some degree New Orleans. So it's important to understand that every community and whatnot has their own nuances to this problem in terms of payer mix and in terms of who's coming through the doors. And every state's going to have their own little nuance to it. So it's important for you to understand that what I talk about is my experience. Again, I try not to speak for either anesthesia or any of the other hospital-based groups that are also involved or would be affected by this legislation. Although I recognize that the problems are the same for the patient. by no means do any of the physicians that I work with or know have any interest in patients being burdened with a bill that they should not be held responsible for. They have insurance, they have coverage, and there's no reason why they should be surprised that they get a bill. So we are very motivated to participate with the Senator and with the state of Louisiana to solve this problem, and certainly with our insurance companies. The physicians in the world and in the state really want our insurance companies to be successful. We know that their success and our success are linked. And so we want to be involved, and I'm happy to be involved. So it gets tricky. So I'm a small business. I have 7 physicians that work with me. We're partners. We contract our service at St. Elizabeth Hospital to provide care, medical care for patients that come into the emergency department. That's what our contract is for. We receive no money or payment by any other source except for the patients who come through the door and our ability to provide service, hopefully high enough quality care that they decide that if they should need emergency care again, that their experience was good enough to come back, should they need it. We have to then send bills to their insurance carrier if they have insurance, and then we collect what is paid to us. I am 92% in network with all of the patients that come through the door. I have 8% that I'm not in network with. The question that many of you might ask is, why are you in network with some and you're not in network with others? And this is where it gets complicated and where it gets tricky. And it is impossible for the general public to understand, which is why we, when I say we, physicians, legislation, and insurance companies have got to get this figured out, because the average public has no reason to try to work their way through the nuance of why a doc or a group is in network with some insurance company and out of network with others. So in my experience, I am in network with the largest payer in the state for a very specific reason. They're the largest payer in the state. They have the most people. If you're not in network with them, it becomes rather painful for you to keep your contract, because the businesses at which have contracted with them receive notice and messages about the physicians at that facility that are not in network, and it's kind of a nasty gram, if you will. Okay, so the businesses are like, well, we've got insurance with them, you know, Chris, what's going on? This gets to administration, et cetera, et cetera. And so it's a very effective means to try to motivate a group like myself, who, by the way, as 7 docs, my voice outside of the 4 walls of that emergency department is essentially zero. Okay, I have no ability to really talk to the business folks in the insurance world with any sense that they're going to take me seriously. So we contract with the groups that have the ability to essentially negative impact me to a rate at which I have no choice. In addition to that, because of that leverage, and I'm sure you can appreciate this, and I applaud the business model, it's brilliant. But because of that, they know that I'm going to be in network, and so their rates are consistent with that knowledge. So they're not great. In fact, if you look nationally, they're like the lowest in the country. So, okay, I'm in. So then I have the other insurance companies, and I go and I talk to them about their rates. And so I've got to make up what the big company has got me leveraged on, okay? So I'm trying to get rates as best I can with the other insurance companies. And of course, they don't feel like that's their problem. That was my problem with the larger insurance company. So at the end of the day, I have to make a decision. And I look at my balance sheet and I say, well, how am I going to pay, and how am I going to have enough resources to have quality and performance? And so it's a strategic decision per insurance company on whether or not I go in network, because the allowable that they would pay was better than the network rate that they were going to pay. I don't balance bill any patients. I accept the allowable. So that's been my practice. So interestingly, as of late, my allowable has gone down. It's not surprising, because as soon as the insurance companies kind of figured out that I'm not a network, but I'm accepting what they give me, I fight for it. I make the argument. but I'm not balance billing the patient, so there's no negativity at that level either to the community or to the insurance company or whatever. So it's gotten less and less. So I'll give you an example. I have one insurer who I'm out of network with. They're a private insurance company, and they are paying me Medicaid rates right now. And so it's essentially like government pay. They will not contract with me. They said, you are out of network, and we've decided to, this is the rate that we're going to pay, and why would we contract with you now, since the contract that we would have offered you, let's say 3 or 4 years ago, would have been higher than Medicare. And so they're perfectly happy. So did I make the mistake by not going in network with them back then? Maybe so. But I don't know that that's what this should be. I don't know that that's the trick bag that the provider should be in. And that's where it's important that the public understand a voice like myself has no ability as a private citizen and as a small business in Louisiana to influence this, short of this sort of discussion, which I'm as much as I hate being here, because I do, I appreciate that it is an opportunity, and I hope I represent my team and my specialty. I have reached out various times and agreed, if the insurance companies would agree, that I will go at risk. Pay me government rates across the board, period, if I don't perform. If I perform, pay me better than what you're currently offering me. I had an interesting conversation in that regard because I wanted to talk about what is the performance. So in my world, performance is quality care, patient satisfaction, throughput through the ER, patient outcomes. Are you recognizing acute MI, heart attacks? Are you doing this stuff, and are you doing it well? And so the discussion that I received was, what is your percent admits, period? And I said, well, it's national average, it's 14%, 12 to 14%. And they said, well, we would like that to be less. Can you do less? And I said, well, I want to talk about performance and quality because the admit rate is only relative to the acuity rate. And they said, no, you don't understand. Our quality is dependent on admit rates, period. That was the only conversation I could have. I could not move any direction on whether or not patient satisfaction, quality, performance measures, or any of that had any impact. To that point, if you all are familiar with Leapfrog, I don't know if you are, but Leapfrog is a national agency that goes out and looks at hospitals and makes determinations on quality and patient safety and whatnot. And it's nationally recognized. And St. Elizabeth Hospital participated in Leapfrog for a number of years. We have had an A rating, I think, 4 years in a row. And this year, which is the highest you can get. And this year, St. Elizabeth was awarded top hospital in the nation, of which there's 120 in the nation that received that award. It was the only hospital in the state of Louisiana that received that award. You would think that that might help me in a negotiation about performance and quality. I have zero ability to get attention in that regard. I'm 7 docs. I'm just a simple country doc who's trying to take care of my parish that I'm very passionate about. And my nights that are sleepless are whether or not my resources will be there for me to make sure that my community is taken care of. And so, so it is a challenging problem. For me to even begin to have a conversation like this with the patient, first of all, is impossible. And second of all, it's really not appropriate. They have their lives to lead. They have insurance. They've come to see a doc. They should just be worried about getting better. And so I could not be more motivated to get them out of this. I am 100% certain in my review, and again, I am not in legislation, I'm certainly not a lawyer, but I've reviewed some of the laws across the country, and I do see that there are certainly some legislation that has passed that is extremely encouraging, where I think there is a very fair and reasonable way to find a payer option where insurance companies and physicians have a mediation of some kind and a leveling of bills or claims where we can agree that this is a common middle ground. I have reviewed Senator Talbot's, I did my homework, Senator, a proposed bill. I think I'm encouraged by his bill, and I'm not saying that because he asked me. I've never met the man before today. But I am encouraged about his legislation in that it reflects in many ways some of the legislation that I have looked at in other states. And so, again, I have not vetted this in its detail, and I would need people smarter than me to kind of figure that out. But I'm confident that if we choose to do the right thing and get it done, it can get done. That will require both parties to make some movement towards that direction. I will stop there because I'm sure the others have time, and I'll be happy to answer any questions.
Great. Thank you so much. Thank you, Commissioner. Thank you, Senator, and members of the panel. So let's kind of talk about what's really affecting people in the room. I'm just going to ask a question. How many people in this room have either been surprise billed or know of someone who has been surprise billed? Show of hands.
Oh my God.
Okay, that right there, I think, speaks volumes to the importance of this issue. We at the Louisiana Association of Health Plans, we've been at the table for at least 10 years trying to resolve this issue. Finally, I think, we have the attention of the specialty physicians who up until now have not really been able or have a common agreement on legislation. So as John Dingell once said, you have to have a crisis or a consensus. And so I'm hoping that we will have a consensus this year, because it's really extremely important that we do hold the patient harmless. The nuts and bolts will be who pays, how much, and when. That's always where it really boils down to. 1 in 5 Americans will be balance billed. The Kaiser Foundation, in their poll from February, said in February, 1 in 3 Americans of those who were polled received a balance bill. And half of those received a bill between $500 and over $1,000. 4 in 10 of those polled said, if I receive a $500 bill, I will not be able to afford to pay it. So this is an extremely serious issue that I think everyone knows we need to address. So the question is, how do we address it? Well, just like Senator Talbot had with his shoulder surgery, my wife had two knee surgeries done this year, one in August, one in December. And both times we went in, and I had called the hospital early and saying, okay, everybody in network, and everybody said yes. So we get there, she's about ready to be taken back, and the anesthesiologist comes in and says, can you sign these forms? I said, I just want to double check, are you in network? He says, I don't know. I said, well, is there a way how can I find this out? He goes, well, if you call my office, I can give you a 1-800 number to call, and then you can find that out. That's not the response that I'm really looking for in terms of my doctor. And at this point, it's really too late. For those of us who are sitting there on the bed with who knows what hanging out, and we know it is, we're going to go through this one way or the other, unfortunately. And Senator Talbot really has done a very good job in trying to promote disclosure and information. But even the most savvy individuals, when even just asking the doctor themselves, and the response is, I really don't know. And it is difficult. I just, for example, because I saw Dr. Trevino was going to be on here, I said, okay, I'm going to call his office, see if he's in network. So I call his office, and they said, I don't know, you have to call this 1-800 number. I said, that's fine, I don't mind doing that. So I called 1-800 number, and he said, well, we don't have his name here, or this is not the right group. And then I find out there are 2 Dr. Trevinos, and so I start all over again. I don't know why. I don't know.
I'm the better looking one.
That's what I thought. That's why I told them. And they still said they didn't know. And that's not just single anybody out. That's just to show how difficult it is to get the basic information that patients need to have to make an informed decision. I mean, that's really what we're trying to do. And in all due respect to our friends in Washington, D.C., I agree with Senator Talbot. I think it's very important that we have a Louisiana solution because we saw what happened at the end toward the end of last year, that there were a couple bills they were moving, and it looked like there was going to be a solution. Then all of a sudden we started hearing these ads on the radio, and you may have heard them from doctor-patient unity. I don't know if you heard those, but they were saying, we don't want big government, meaning your elected officials, or insurance, determining, what people get paid, and I certainly respect that. But then they said, well, call Dr. Cassidy, call Senator Cassidy, and tell him that, we need your help. Well, they spent probably about $400 million across the country trying to kill legislation in Washington, D.C. that was moving forward to some sort of compromise. And that's not the way I think we need to do it. I think, just like the doctor said, we need to be in a room and sit down and see really what's best for Louisiana. What's best for Gonzales? What is best for Shreveport? I mean, we need to have that solution. Now, all due respect to Senator Talbot's bill, I don't like it as much as the doctor likes it, but this would be a work in progress. There's obviously been some discussion on benchmarking and arbitration, and that's really inside ball game sort of discussion. But arbitration increases the cost of care. And that's one thing that really concerns us the most. We had the Congressional Budget Office do their markup of certain bills, and those that have arbitration save less dollars than those that don't. And so there's a lot of I think there's still a lot of compromise that we can have when we work together and when we move forward. So I'm just going to stop right there and be happy to answer any questions. But thank you, Commissioner and Senator.
And I'll chime in a little bit before I have to go. Well, Dr. Trevino, the reason why you would want this to be solved on the state level is because you can come to my committee and testify. If there's a right, you think this is bad? No, more fun. We have a great cafeteria. But you want to be able to get your voice heard. You're not going to get your voice heard in Washington, D.C. Good luck with that. And trying to get an appointment with the chairman of whoever the committee is that would handle that was probably next to impossible. But the good thing is this is not a partisan issue. We don't have the usual challenges of Republican versus Democrat or rural versus city or black versus white or rich versus poor. This affects everybody. So this is not a partisan issue at all. But I guess the devil's in the details, right? Who's going to decide what's reasonable for an out-of-network expense? And and I'm sure Commissioner DONELON will agree. The challenge we have as legislators is, you have the 3 parties involved: the hospitals, the doctors, and the insurance companies, and they want us to pick a winner. They want me to pick the winner, or whoever, and that's the hard part. The only winner I'm trying to pick is the consumer. We don't want to hurt hospitals or hurt insurance companies or anything like that. We know we all need to exist, but there's different ways to tackle this. I mean, we can rate set, or we can go to arbitration. We can go to binding arbitration, non-binding arbitration. One thing I did look at, and the bill I filed is not a finished project. It was a process. It was kind of a shell bill, we call it, just to kind of get something scheduled on there that we could deal with balanced billing. But I did file a bill similar to that 2 years ago, and the thing I found out about arbitration in New York and Texas, which have really had these arbitration style systems, nobody arbitrates. They know what it's going to be. Once you get the idea of an out-of-network, let's just say an anesthesiologist, non-complicated procedure, they know what it is. So they're not going to go. I like that system as far as, well, one, in some states you have an arbitration where the arbitrator picks the number, or the arbitrator comes up with the number. Some states like New York, they do the baseball style arbitration where you pick a number, and the arbitrator is going to go with the lower number. So it encourages companies, don't go in there and highball them because you're going to get burned. So, you know, be reasonable, and I think that encourages both parties to come up with a reasonable amount. But again, you know, that's the devil's in details. I kind of use the Hilton Honors card example. I get it. If I'm not in network, I shouldn't get the in-network price. You know, if I'm not a Hilton Honors member, I shouldn't get the discount on the room or get the free room every 10 times I get it. I book a room, but, you know, you can't have out-of-network costs that are 400% or 500% higher than the in-network price, which we see all the time. So hopefully we can come to some kind of agreement, but, you know, we need to take the consumer out of it, and we need to solve this problem before the federal government comes in and solves it without our input and without our ability to take care of unintended consequences. And, you know, do I have faith in the government, federal government, that they're going to pass this? Absolutely not. I mean, just look at how they act. I have no faith that that's going to happen. I think it's just going to drag on and on. But, you know, we have enough intelligent people up here that are trying to do the right thing. Nobody's trying to, you know, put anybody out of business or anything like that. But I'll let the rest of the panel speak on that, or if anybody wants to ask any questions. I do have to leave at 3:50 or 3:55, so I apologize for that.
On an elective procedure, when the patient or the consumer has done due diligence in checking all the boxes necessary and then coming up goose eggs and only be told that, well, I don't know. That's not, as a consumer, that's not what I want to hear. I want to hear that you're in network, and I mean, there's another bill that's out there that's on the House side that just says that if you're going to be in an in-network hospital, you have to be in network. And that sounds pretty simple, but it's very, very complicated and very controversial. But, you know, once again, you go back to the consumer and go back to looking at the high cost of health care. You know, we look at these cost drivers. How can we limit the high cost of health care, whether it's pharmaceutical drugs or whether it's surprise billing? And, you know, when you have, you know, these specialty docs that are charging, you know, 5 times, 6 times of Medicare, a Cooper and Morton study of ER docs had one study where they were charging 798% of Medicare. Now, those are anomalies, but that shouldn't be happening. The consumer should not have to go through that. We should pay the bills, and they should get quality care.
So I think Dr. Fresh's question was not necessarily if it's okay to bounce bill someone who comes to the emergency department versus an elective. So I don't want you to be misguided in that direction. His question was about the fact that if someone has a knee problem, they can choose and look to see where and how they want to get that done. And the doctors can choose or elect to accept them as patients. They don't have to take them as a patient. They can say, gee, you're out of network. Yeah, why don't you find someone in network, and they move on. So there is a difference in terms of how that relationship, both between the doctor and the patient and the payer, goes if you have a elected medical condition. In emergency medicine, we are federally mandated to see anyone who shows up on campus and says, I want to see a doctor. And it doesn't matter if you are from Wuhan, China, and you come in, and you not only do you not speak English, not only do you not have any means to pay, but you're a high risk to infect my entire community, I don't get to say no. My answer is, I have to treat you exactly the same as I would treat the senator if he walked in to the emergency department. I have no ability to select or even to reduce the amount of care that I choose to give. Everyone has got to be treated exactly the same, have the exact same amount of attention and the exact same amount of resources by me and my staff. So it's not that then makes it okay to balance bill. That is not my argument. My argument is process that we have inherited in healthcare as a result of that legislation, and then the fact that we are still in this fee-for-service world, puts the emergency department in a trick bag that we don't get to select folks who don't meet the ability to resource our care. I would ask the senator if it's okay with him to give every 5th hot dog away free, because the federal government says you have to. And by the way, of the 4 hot dogs you're charging for, 2 of them, the federal government is going to pay you the rate that they decide. And so now you're left with 2 hot dogs. One is in network and one is not. Okay? So that's and there's no choice. He has to be prepared to give those hot dogs when that customer shows up and says, I'm hungry, period. No questions asked. So the trick bag isn't that we're trying to convince it's okay to balance bill and stick a patient with a bill. By no means. But the field is not necessarily level, particularly in the emergency department, for those reasons.
Members, I'm here to tell you that I lose money on 2/3 of the patients that come through the doors at 400-bed East Jefferson Hospital. That's the 2/3 that the federal government and the state government, Medicaid and Medicare, pay me to treat. I make it up on the other 1/3 that comes in with private insurance. So we, in the private insurance world, and I represent policyholders first and foremost, we pay the bills and make up and do the right thing and pay more than our fair share to get that insurance. Then we go into a hospital and deliver a baby. And my daughter went into that hospital and delivered a baby and got an anesthesiologist bill from a doctor she had never met and said, I was treated by my OB for 9 months and through the delivery. She got paid less than the anesthesiologist who treated me and I never met and sent me a bill for more than she got paid. It's just wrong. And my solution, after starting out down the road of forcing a fee schedule on the medical profession, which was anathema, and they explained to me that is communist. You know, it's not social, it's Bernie plus, and no way. And so I said, okay, then I have a 1-sentence solution. And that 1-sentence bill I introduced for several years running said, if you go into a in-network facility, I actually took the emergency out. I just concentrated on the in-network facility to be treated. Your 99% of the population can find out if their hospital is in-network. They have no clue who the ancillary physicians that are going to be called in to treat them are, or if they're in network. Don't know how to call the 800 number to find out if they're in network or not. If you go into an in-network facility and are treated by an ancillary physician, then that insurer and that hospital have to duke it out. And that's what they really used to do very commonly in the past. But the patient pays the in-network deductible and copay and is out of the issue. And it's between the big insurance company and the big hospital and their ancillary physicians that they hire. But couldn't get that done. And the war continues. And frankly, it's a war between medical providers, including hospitals, and health insurers, who both, truthfully, are benefiting from the system. It prevents rates from going up for health insurance. I get that. I understand that. And it makes more money, or they'd be in network, for those ancillary physicians to operate through the balanced billing system. Not unique to us, not unique to our doctors, our health insurers. When I started down this road, it was very few of us who were, I spent a half hour out front of the LSU the LSU Athletic Administration Building, explaining to a writer for the New York Times how balance billing works while I was picking up my season tickets one day. And she blew up my quote, I think, to repay me for all the time I spent explaining balance billing to her as she wrote a front-page headline story in the New York Times that resulted in New York fixing it. And now, 10 years later, about half the states have fixed it with either a fee schedule or an arbitration model. And it's really not on them to fix it. It's on us, the public officials charged with representing the public. I am amazed at the hands I saw. It has impacted everybody in this room. And I thought it was just a small percentage. I have never been impacted. And I have asked my wife, I wonder if when I went in for my cancer surgery at East Jefferson, if they have me flagged not to send a balance bill to me, because I didn't ask. I still don't know. But I didn't get a balance bill. And it cries out, and it is, in my judgment, having been an insurance regulator for 20 years now, the most egregious abuse of insurance policyholders doing the right thing by insuring themselves and paying more than their fair share for their health care. This needs to be fixed, and it needs to be fixed truthfully by the elected officials with that responsibility.
Hi, I just want to echo some of the sentiments that the consumer should not be in the middle of this. And I did want to thank Commissioner DONELON and Senator Talbot because they were instrumental in the existing legislation that Louisiana does have regarding balance billing. And one of the key components to that was to take a look at who was in the best position and who had the most knowledge about who was in network and who is out of network. And when you think about it, it's the health plans. So any consumer who is going in for that elective knee surgery should be able to ask their provider, hey doc, where do you have privileges? What are my hospital options? And then you go from that point on. And all of those hospitals are typically going to have one anesthesia group. They'll tell you, okay, it's Parish anesthesia, or it's this anesthesia group. Okay, who's radiology, who's pathology, depending on what kind of service that I'm going in for. And it's up to the health plans. The health plans know which providers they have contracted with, which providers are in network, and which providers are not. It's up to the health plans to make sure that their provider directories are up to date. And so as a consumer, you should be able to call your 800 number on the back of your card, your insurance card, and say, okay, I'm going in for a procedure. Which hospital should I go to? And tell me what the providers are. The health plans have all of that information. The question has to go to, it's I guess more of a statement that the providers, we heard from Blue Cross, a gentleman from Blue Cross, that hospitals have pretty much kept their rates and that providers are the ones who are seeing their revenue ratcheted down and shrinking. And so in order to preserve our very good quality care that we have in Louisiana, we need to make sure that all of the players are at the table and that we don't end up with a situation where those hot dogs are given away for free.
I think you bring up a very good point. At the same time, just like in my experience, I've done everything necessary that I had to, and we've heard of many cases where they meet with the anesthesiologist, yeah, I'm in network, then they go there, and on that very day, someone got sick, and all of a sudden they did the switcheroni on them, and I understand that because they have to provide services, but the health plan can't be held responsible for a decision that was made maybe 6 hours before somebody walked into the surgery. So, and by law, we have to update our provider directories, and most plans update those at the least on a monthly basis. So, I think the real discussion is a little bit more complex than that, but kudos to Dr. Trevino for not balance billing. I mean, that is, I think, a very strong statement on how he decides to run his business, and kudos for him. However, that's not. I would probably say that's probably not the norm. And that's why all these hands went up and why we need to continue working on it.
So just a comment or two. So understand there's a difference, I want to make sure we're clear, there's a difference on balance billing, and we've talked about what that is, and a patient responsibility for the bill. Many of our insurance plans have high deductibles, as you are aware. It is often quite surprising to the patient, number one, how high their deductible is until they start to use it, and number two, that they have not met it. It is quite common that a bill is sent based on that. It gets thrown into this big surprise billing bucket, bad doctor again, when the truth is, it has a lot more to do with either their understanding of their plan, the recognition of where they are in the plan, but guess who's chasing the dollar? Me, okay? So that's another little je ne sais quoi, as we say in Louisiana, to this little nuance. I will tell you that insurance, cost of insurance, cost for coverage for a business has gone up. The cost for the individual has gone up, particularly if you include the high deductible plan. Providers have never had a more difficult time, in my experience, and I hesitate to speak for all of the providers out there, but in my experience, have never had a more difficult time in collecting. In many cases, I've seen my what I can collect going down. And it's interesting that concomitantly with this time frame, and I just pulled it up on Google, United Health earnings 2019. If I did the math right and I annualized it, which I may not have, but let's say on the low end, 11 billion. On the high end, 18 billion. That's with a B. Unprecedented amount of profit during the same time that you see the cost going up for business, the cost going up for the individual, the difficulty in getting reimbursed on the provider side. And I'll be honest, it aggravates me that I'm the bad guy here. When I'm the one sitting in the chair 24/7, I'm the one who's taking care of whoever walks through the door, and the hot dogs are given away for free, at least one hot dog out of 5. And yet I still produce, at least the hospital and our efforts are producing at a high level, as recognized by other outside agencies, that I get zero credit for any of that. And I'm fighting for the survivability of my small business. So I get the problem. There is no one more motivated than a guy like me to solve it, and I'm in. But we have to have some method that levels that playing field, and it's not leveraged so heavily for a guy like me in an industry that has way more resources to leverage against a small business who's doing their job. So that's my ask to the senator and to the officials. I will say this, it's an ominous task. If they get it wrong, the downside of this could be tremendous, because what we're talking about in many cases and in many ways is a melting away of the safety net of our community, particularly in rural environments where there's already significant shortages of physicians. And it's interesting we have this meeting on what is potentially the cuff of what we're seeing as a enormous, potentially worldwide medical problem. Okay, so these folks, should we end up with a significant coronavirus issue across this country, is going to impact access and care. So it's interesting that at the same time that if this legislation isn't careful and if we're not right about how we do this, the very fabric at which we and our communities are going to rely to keep our families safe could be easily, slowly but surely melted away. And we've seen this in states that have had legislation that is not a good legislation. Hospitals have closed, doctors leave, they move to another place. So I wish my officials not just luck. To a certain degree, I think we should pray for them because it is a tough job that they are fixing to do. But I'll be honest, you wanted to be elected, get it done right.
You're up.
You're absolutely right, Doc. No question about that. Let me add a couple of observations. Number one, you're right about United Healthcare. When I was chief deputy and represented the department on the advisory board for the Office of Group Benefits, we put out a product and had presentations from all the plans, from Blue, from Humana, United, whoever, Aetna, and United led off their presentation, to my shock, and I've quoted it many times since. Members of the board, we're here to tell you that we're the 40th largest by revenue corporation in America, and 39 is Microsoft. So that gives you some idea just how big United Healthcare is. Having said that, they don't want our individual insurance business. I have tried every which way to get some competition for Blue Cross in the individual market for over a decade, and I'm losing ground now that I lost Vantage to acquisition by Blue Cross last year. Having said that, I had a meeting with Mike Wrights when he was president of Blue Cross in his office one evening, and I complimented him on the year they had just finished and whatever their reserves were at the time. It was a lot of money, and I observed on how well they were doing and how good a job he was doing, and he said, yes, Commissioner, that's true. We had a good year, we're doing well, but know that if we had a pandemic, I have $750 for every policyholder I have insured in Louisiana. In that perspective, they're not doing as well as you might otherwise think. So it's quite the challenge, and the doc is right. It's better be right. And that's why I'm so anxious to have us do it and not the feds. That's a real shot in the dark. If they do it, we don't know what that's going to be, but we're going to live with it like everybody else. And half the states have fixed this, and I've offered through Senator Talbot, I'd be the mediator. My bean counters at the department say, we don't have money for that, DONELON. Don't go offering to take on more responsibility. But if they wanted that as the arbiter between the two interests, I can make that happen at our department. I believe, like Senator Talbot, after a couple of tries, it would no longer be brought to us. They would figure out what the program is and accommodate to it. It is a tough issue. It's a complicated issue. But kind of like tort reform, I hope and I think that the moment is now. I think the issue has risen to the public's awareness, and that will bring the legislature to the solution as well.
My advice in terms of how we can best improve health care is to have health care coordinated so that consumers can take more charge of their health care, and they can have a primary care physician who can help them navigate the system for them so that they don't end up in the emergency room, which is expensive and uncoordinated health care, where they end up maybe getting unnecessary diagnostic tests, or whether it's a real emergency or not, whether they can't get in to see their primary care doctor. I think those are discussions that we need to have. And I think that would really improve the system of health care in Louisiana.
How can people get more information about the variety of insurance topics talked about here today?
Our website, www.ldi.la.gov, or call us, 1-800-259-5300. 259-5300. We can direct people, if they don't find it on our website, to information from our two-day meeting here in Baton Rouge.